Hello, everyone, and welcome to Achieving Telehealth's Potential, the Federal Policy Landscape for Interstate Telehealth Practices. I'm Carmel Shachar, the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard Law School's Executive Director. I'm excited to welcome you to this event. I think it's a really important conversation. Before we start talking substance, however, a few housekeeping remarks. First of all, we're reserving a significant portion of this panel for a moderated discussion involving audience questions. So we strongly encourage you to submit questions, which you can do so at any time by using the Q&A feature found in the meeting control at the bottom of your screen. I'll be seeing all questions submitted through the Zoom Q&A feature and putting them in the queue to ask our panelists. You're also welcome to join the conversation or even submit questions on Twitter. We're at Petrie-Flom, again, at Petrie-Flom. We will be sharing the fully captioned event video with everybody who registered, so you as well as the other people who registered within 1 to 2 weeks. Please feel free to share that link widely with anybody who you think might be interested. If you have technical issues, and I hope you won't, please email us at petrie-flom@law.harvard.edu. Again, that's petrie-flom@law.harvard.edu. That's the best way to get our attention, and if we can help you, we will certainly do our best. If you enjoyed this event and are curious about our other events, I strongly encourage you to sign up for our newsletter. It comes out only twice a month, so it's not going to clog your inbox, and it's the best way to find out about events coming up, scholarship, what we're posting on our blog, opportunities to get involved with the center, as well as what our alumni and affiliates are up to. Speaking of the blog, I'd also encourage you to check out our blog, Bill of Health, which translates some of the most cutting-edge bioethics, health policy, scholarship into concrete, easy to understand pieces. We often run digital symposiums on issues such as the interplay of adoption and abortion, or upcoming, we have one I'm very excited about, looking at disability and climate change. Please also check out our upcoming events. We have a very robust event calendar, including the sequel to this event next week, looking at state policies around telehealth licensure. But we also have a series on psychedelics regulation around the world, and we have a bunch of programming on health law as private law. So with that, a few substantive remarks now that we have finished with our housekeeping. So telehealth has really exploded in popularity and use over the last several years, especially with the COVID-19 pandemic. And what we know about telehealth is that it is an amazing extender for access to care. I remember reading early surveys in the pandemic of who really liked telehealth. And unsurprisingly, for example, parents of young children who might be very busy, but often have a lot of reasons to visit a physician, really, really liked it and appreciated it being more available during the pandemic. The pandemic had somewhat of a silver lining in that it saw a lot of regulatory experimentation, and telehealth has been no exception to that. States, I think, took a look at how they could build a more flexible clinician workforce, especially with the pandemic not being evenly distributed across the country, but sometimes coming in waves in the Northeast or the Southwest, for example, and relax some of their licensing requirements. During the time, a lot of health law scholars talked about, oh, this is great. It's really showing that we don't necessarily need to stick with our older model of regulating physician practices, that maybe this is the start of a new age that really facilitates physicians having a telehealth practice across state lines. What we're finding now is we come to the end of the federal public health emergency, which is one of the legal structures that has really allowed for this regulatory shift during the pandemic, is that if anything, things are being walked back to pre-pandemic, that we're going back to a very state-focused system. This is an interesting inflection point to consider, okay, why do we do that? And if we truly want telehealth to be a major way of delivering access to care, what are the trade-offs of going back to this very state-focused licensure system? This panel is one in a series of 3, and it's going to focus on the role of the federal government, federal policies, to innovate in this space and to take us to where we need to go, however that is defined by our speakers. I'm going to briefly introduce our speakers under the theory that you'd rather hear from them than hear me gush about them. But if you're interested in reading more about them, please go to our event page where we have their bios linked. In order of how they'll be presenting, we have Lita Anderson, Director, Advocacy and Government Relations, Advocacy, Government and Community Relations at the Massachusetts Medical Society. We have Krista Drobak, Executive Director, Alliance for Connected Care and partner Sirona Strategies. We have Leonie Hayworth, Deputy Director for Clinical Services, Telehealth Services, Office of Connected Care, Veterans Health Administration at the U.S. Department of Veterans Affairs, and Craig Lipset, Co-Chair, Decentralized Trials and Research Alliance, and Adjunct Assistant Professor of Health Informatics at Rutgers University. So Lita, you are our first panelist. I'd like to welcome you to the virtual stage.
Thank you so much, and thank you for having me. I'm really excited to be here today and to provide the Medical Society's perspective on this incredibly timely and really complex issue. As Carmel was discussing, since the onset of COVID, telehealth has become, an essential part of the healthcare infrastructure and a really invaluable delivery modality to improve access to care and health outcomes for patients. So advocating to advance access to care via telehealth is a core priority for the Medical Society, and our advocacy is really is guided by our policy, which is established by our House of Delegates, which is our policymaking, our physician policymaking body. In 2021, our House passed new policy on this issue, directing advocacy for a regional reciprocity agreement to be able to care for established patients in neighboring states. But I think, given how quickly things have evolved, even this policy approach doesn't necessarily provide an adequate solution for the challenges that our physicians are facing in wanting to practice across state lines. And it's something that I hear about constantly from our members. And, notably when it comes to telehealth and seeing patients out of state, the primary issue that we hear about from our members is about the ability to maintain continuity of care for patients, especially when it comes to prescribing. But I will say, the issue of licensure and telehealth has been challenging for us, especially in considering the role of federal regulation or oversight of licensure and the practice of medicine. The regulation of the practice of medicine is so sort of deeply ingrained on the state level, and historically organized medicine, including our medical society, supports state-based licensure. And while we absolutely recognize, the challenges it presents when it comes to telehealth and the need to think outside the box and sort of innovate in this space, we also recognize that there is value provided in the licensing and regulation of the practice of medicine on the state level. There's value in the role of state medical boards in serving the public and keeping patients safe and ensuring quality medical care by setting standards for the quality of care. Boards play a very important disciplinary function, overseeing the rehabilitation of physicians dealing with mental health and substance use issues, and the important role of regulating sort of continuing medical education, which varies dramatically by states. It's not even required in some states. It's very stringent in others. Massachusetts has a sort of fairly rigorous requirements depending on the patient population you serve. You may have learning requirements relative to diagnosing and treating Alzheimer's disease, recognizing and reporting suspected child abuse, domestic violence and sexual violence training, end-of-life care, opioid education and pain management, implicit bias training, to name a few. Some of these educational requirements are tailored very specifically to Massachusetts law. All physicians are mandated reporters, but mandated reporting is very different, is regulated very differently in every state. And I think from a patient perspective, there's a lot of value in that training, and patients in Massachusetts, I think, are benefited by improved quality of care coming out of these continuing medical education requirements. But of course, there are significant drawbacks to state-based licensure when it comes to telehealth. When our members approach us and they want to know, can they see their patients over the border in New Hampshire or Rhode Island, or when they're traveling out of state, they're frustrated to when they learn that they need to be licensed in the state where the patient is located, because from their perspective, it makes no sense. It's their patient. They want to be able to continue to care for them, regardless of where they are. And we're obviously very limited right now in what we can do in Massachusetts. We can only sort of regulate, who's seeing our patients here in Massachusetts and not in other states. And the patchwork of approaches taken by states right now is definitely challenging and burdensome for Massachusetts-based physicians for them to navigate when they want to continue to see their patients, whether it's telehealth only license in other states, a registration model, each with sort of different parameters and requirements. And obviously that's a challenge, and that's what we're here to talk about today. And the first question that we always get asked is, why isn't Massachusetts part of the Interstate Medical Licensure Compact, and does the MMS support the IMLC? And unfortunately, it's not a very straightforward answer. We don't necessarily have a position for or against the IMLC, but I also think a lot of people don't necessarily understand how in practice it actually operates, because there's absolutely value in the compact in helping to streamline the licensure process, especially for our physicians practicing in border communities that have whole patient panels across state lines. But the construct of the IMLC still requires physicians to obtain a license in each state where they want to practice, which means you have full licensure fees, and you're subject to the continuing medical education requirements in each individual state where you want to be licensed. And that's incredibly cumbersome financially, administratively, and it's not necessarily very practical if you're looking to be licensed in more than a few states. So, while it has its benefits, it doesn't really provide, I think, a viable solution in the context of telehealth. And we do support reforms to the IMLC as well, especially regarding its disciplinary framework, which has been challenging. It used to be that if a physician's license was suspended in the primary state of licensure, it was automatically suspended in all other compact states where they were licensed. And those rules were recently amended, so that sort of cascading disciplinary requirement is permissive now rather than automatic, but it's definitely still challenging, especially in the context of the new law that Massachusetts passed this past summer, establishing licensure professional protections for physicians and providers who offer what Massachusetts considers to be and defines as legally protected healthcare services, so reproductive healthcare services like abortion, gender affirming care, et cetera. And I think that sort of segues to one of the larger challenges with a lot of these proposals, be it a national licensure model, a reciprocity model, and to an extent a registration model. There are definitely sort of pros and cons to each, I think, but a sort of overarching challenge is the sort of increasingly polarized politicization in the regulation of the clinical practice of medicine. It's hard to look at licensure itself in a vacuum, but within the context of the regulation of the practice of medicine, there may no longer be significant variations in the standard of care or the educational and training requirements for licensure, but the impact of political dynamics on clinical practice are sort of reinserting even stronger geographic variation in the practice of medicine that really make it challenging to have a sort of cohesive nationalized approach to licensure. So certainly, like in the post-obs era, there's new challenges, but even long before, states across the country have been regulating the practice of medicine in ways that undermine patient access to evidence-based medically necessary care, and that interferes in the physician-patient relationship to the detriment of patients. It was certainly top of mind when we were working with policymakers on the comprehensive reproductive health care law. And, for example, when you're talking about a reciprocity model, I think there's going to be a lot of resistance from states when you're talking about a law that's going to require them to automatically authorize physicians from other states to practice into their law with no other sort of oversight or regulation. Folks in Texas may not want Massachusetts-based physicians offering medication abortion or gender-affirming care to patients in Texas, and vice versa. In Massachusetts, we've prohibited conversion therapy. We wouldn't want a physician from out of state, performing conversion therapy on a minor here. Ditto for, issues concerning medical prescribing or prescribing of medical cannabis, end of life care, medical aid in dying. There's a lot of questions, I think, when it comes to that in terms of what states' laws govern. Is it still where the patient is located? What are sort of the legal and professional risks and exposure for the physician? At least with a registration model, like in Florida, or telehealth-based licenses out of, like, for example, in Georgia, where a physician registers with the state, there's some level of oversight, and the state has sort of standing, I think, to intervene because they have that relationship with the physician who's registering with them and affirming that they're going to follow the laws and rules of that state. And obviously something like that is a challenge to implement because, like the IMLC or the compact, it's going to need to be adopted by states across the country, which is obviously cumbersome and challenging. But this does seem to sort of, the registration model does seem to be a direction that a lot of states who have adopted, interstate telehealth, the direction that they are going. I think you see, like, the Uniform Law Commission Telehealth Act has very clear guidance and a framework in terms of acknowledging that the services delivered need to be consistent with the standard of care in the state where the patient is located. But obviously, to be successful, I think the sort of administrative processes and costs associated with a model like that need to be kept at a minimum in order to enable sort of broad uptake and participation. I think I'm probably close to time, so I think I'll stop there.
That, I think, was a wonderful dip into the pool. And now, Krista, it's your turn to guide us through this.
Hi, good morning or afternoon. I don't know, wherever you are in the country, good morning or afternoon. I'm Krista Droback, Alliance for Connected Care, and also a partner at Serona Strategies. I have to disclose my bias that I'm personally deeply believe that we need to allow more patients to be seen across state lines. There is no reason why parents whose child has just been diagnosed with epilepsy should have to get in the car and drive 3 states over, or a patient who had surgery in another state in their region has to get back in the car for their follow-up appointments, or even college students who are getting mental health care at their college when they go home for the holidays, which can be stressful, or their summer job. They can't continue to see their counselor that they've developed a relationship with at college because that counselor might not be licensed in the state where the student is doing their internship. So there's so many use cases that to me just make absolutely no sense. And I'll say, I do think that it makes sense for someone who is barred in a state because there are different laws in every state, whereas practitioners are largely practicing based on clinical guidelines, and we're all human. And so the idea that people are different state to state is makes the whole situation with a law bar different than the licensing situation related to clinicians. So we've been working on this kind of crazily since 2019. I look back on our 2019 selves and think, I don't know how we thought we were going to do anything because we had zero data. But when the pandemic hit, all 50 states waived some form of their licensing requirements and opened up a lot of gateways for patients to see their practitioners. There are two really good studies out, one from Harvard, Ateeb Maroda, who's on the line now, and I think is going to be talking about the study next week. And then another one from the University of Michigan. And it really is a small amount of cross-state licensure that's happening, but it is happening in regional areas. So I live in DC, and there are amazing facilities in all three states, DC, Maryland, and Virginia. And people were seeing those practitioners across state lines in the areas where there was significant regional like closeness. And then also in places like Wyoming and North Dakota, where 20% of the telehealth visits were with out-of-state clinicians. So I don't want to go into those studies too deeply because I'll leave that to them next week. But we did get enough data during the pandemic to show that cross-state licensure is a useful tool in giving patients access to care. We did our own survey of both practitioners and patients. So it's on our website, connectwithcare.org. But we found that 1 in 5 practitioners provided healthcare across state lines under one of the waivers during the pandemic. And 64% of the practitioners that we surveyed said that the rolling back of the cross-state licensure waivers would reduce patient access to care. 8 in 10 telehealth patients, not practitioners, but patients, support the option of receiving care across state lines. And then back to the practitioners, 84% supported the option to be able to use telehealth across state lines. So people really liked it, and I think obviously this shows that practitioners thought that they were increasing access to care. Those licensing flexibilities have now expired in most states. We looked at it last time in mid-December of 2022, so just a few months ago, and 42 states had let their licensure flexibilities expire. We worked with 230 national organizations, mostly patient groups, to urge governors to extend those flexibilities because they still had the ability to keep the waivers in place until the end of the public health emergency, but 42 states let them expire. So we are back to, in many cases, the pre-pandemic rules, which create a lot of barriers to seeing your practitioner across state lines. There's a patchwork of state licensing laws, which we've heard already about. There's also a lack of standardization in the processes for getting your license. Each state has different forms and different requirements. In DC, you need 3 personal references there, which is different from Maryland and Virginia. So it's very cumbersome. And if you look at the compact, so when I talk about this to folks, they'll say, oh, well, what about, this compact or that compact? Well, we have so many compacts. We have a physical therapy compact, a psychology compact, a counseling compact. We have an occupational therapy compact, a nurse licensure compact, an interstate medical compact for physicians. We have a speech and audiologist compact. We have an emergency services compact. We just have all of these compacts, all of which were written by licensing boards themselves, and they are mostly not mutual recognition compacts. The RN compact is a mutual recognition compact. You still have to get a compact license, so that's still additional paperwork, but at least you can practice in non-compact states with that mutual recognition compact. The IMLC is not a mutual recognition compact, and you still have to be licensed in the state where the patient is located. We have collected just anecdotal data from our own members about the Interstate Medical Licensure Compact, and there is no universal background check. You can't use your FBI background check state to state. There's still a bunch of documents that can't be uploaded into their credentials verification system, which is the real value of that compact, that they will store your documents. Not all states have the ability to participate in the online services and can receive licenses online. If you were to take all of the states that are part of the IMLC and add up the fees, the initial fees, the renewal fees, and then the compact fees, one of our members estimated that it would cost $14,000 every few years to receive a license through the IMLC in the participating states. So it's still expensive, still cumbersome, and you still have to be licensed where the patient is located. So what are we trying to do about it? We have multiple, the Alliance for Connected Care, and we do have a section on our website dedicated to cross-state licensure. And if it's not already clear, we're lobbyists in DC. We did try to tackle a state level initiative 2 years ago where we tried to get a regional compact in the DC area, mainly because there is so much cross-state licensure happening, licensing activity happening in DC. And we just failed miserably. It was such an uphill battle, so many entrenched interests at the state level. And so we decided to try a federal approach. So we are advocating a couple things. One is we are working on a bill to create which is like a driver's license compact. And the key features of it are that the provider has to abide by the laws where the patient is located. So just like with your driver's license, you have to obey the laws and the speed limits and the parking laws in the state where you're driving, even if you are using a license from your home state. So that's one key feature. Another one is a coordinating body that coordinates complaints among medical boards, so that if you are practicing out of state and a patient has a complaint, they can call their own medical board, but there is a way to coordinate with the practitioner's state medical board. Another feature is there's nothing taken away from the medical board. They still do all the things that they do. They license practitioners, they ensure that they're in good standing, they administer disciplinary action, but they're doing it for the practitioners who are domiciled in their own state, and then they're coordinating on behalf of that provider with other medical boards to the extent necessary where the patients are located. And then finally, the state has to opt in to the compact. So it is not a mandatory compact. It's, again, the states can do what they want. If they want to participate, great. But it would permit practitioners to take their license across state lines through telehealth to see patients. And the bill actually instructs HHS, Department of Health and Human Services at the federal level, to go through a stakeholder engagement process to develop the compact, which then again is voluntary for states to join. The other thing we're doing is we're trying to exempt clinical trials from state licensing rules. There is a massive effort to decentralize clinical trials, which Craig is going to talk about, so I won't dwell on it. Just to say, if you are trying to increase your recruitment and diversity in clinical trials, having those state barriers is difficult. And then I just got approached recently about this college student issue, that we have this mental health crisis among college-age children. I guess they're not children at that point, adults, and they're not able to see their counselors across state lines. And I say to myself, well, like, when does it end? How many use cases do we, how do we separate these all out? Do we do, rare disease consultations or post-op consultations and make all different, exceptions for all of these different disease states? or treatment states, or do we try to create a national infrastructure for patients to see their providers across state lines? So I encourage you to visit our website if you want to get involved with us. We are really trying to push this envelope and in Washington, and could use your help. So thank you.
Great. Thank you, Krista. And as somebody who works at a university, I think your note about students who are attending school outside of the state that they grew up is a really pertinent and interesting one. I'd like to now welcome Leonie Hayworth. The floor is yours.
Thank you so much for the opportunity to come chat with you today. Really excited to share our VA experience as a national integrated healthcare system. This has obviously been an issue that has been of great interest to us. Historically, and I kind of divide this conversation as pre-legislation versus post-legislation. So let me first talk about the key piece of legislation that drives this conversation, and that is the VA Mission Act of 2018. So a big part of that legislation actually focused on community care and offering veterans the option of care in the community based on certain wait times and access standards that were established to receive VA care, and that eligibility for community care and those community care contracts. So as well as that, within and embedded in that legislation is our anywhere to anywhere legislation, so-called, and that establishes the authority for VA healthcare professionals to deliver care across state lines. So as a federal healthcare system, and especially within the Office of Telehealth, we always describe and talk about telehealth and its potential as far as accessibility, capacity, quality, and experience as being our main tenets and focus, and that really capturing the essence and the potential of telehealth in a national healthcare system. So we realized that we really weren't able to achieve that on all of the levels that we wanted to without a legislative proposal and without anything that legislatively gave us the authority and the broad authority to do that. What we had before the legislation was, as folks have discussed, a patchwork of state laws that could be restrictive as far as providers' interpretation as to whether they could or not have the authority to practice across state lines. So while there was video care being delivered across state lines, for example, from a VA facility to a VA facility, federal land to federal land, fewer questions about that, but questions still came up with respect to, well, you know, if I'm managing this situation in my particular state, my state of licensure has these following guidelines, but my patient is in this other state, even though they're on federal property. If something happens and I'm legally accountable, to whom state law am I legally accountable to? And as you imagine, this came up a lot, particularly with managing high-risk mental health situations. And so hearing about these stories and these situations, just as others have described, really propelled us to say we need a single national standard that we can function on for our VA providers to be able to say we have federal supremacy over our state laws to practice in this way. And so that not only would clarify the questions that came up with respect to facility telehealth, but VA's broader vision to deliver telehealth outside of our bricks and mortar VA facilities and into veterans' homes. And that was really the big goal. And that legislation in 2018, that Mission Act Anywhere to Anywhere section that gave us that authority to practice across state lines, really opened the door and gave providers something that they understood without the complexity, Krista, that you're talking about, of all the complex things at the state level, and then the state where I'm providing to care and what that describes. And a lot of this legalese is very difficult for the average provider to interpret, and very difficult to know if I'm delivering that healthcare And I want to be responsible. I think I understand, but the language is so complicated, I don't really understand. So having that legislation in place gave people the security in very simple terms that I can, as a VA healthcare professional, deliver care across state lines, outside of bricks and mortar VA facilities, into veterans' homes, regardless of the veteran's location. And so this could be the veteran's home, it could be where the veteran considered home for that day, and has given providers a great deal of flexibility. Not only that, but with respect to our key tenets of accessibility, capacity, as a national healthcare system, we can really leverage our resources to answering the questions and facilitating access where it's needed. So for example, in our more rural locations where care might be more difficult to access, on the singular level, you might be able to offer a veteran a video visit into the home so that they don't need to travel 4 hours to their nearest VA facility. On a broader level, that veteran might have a highly rare type of cancer, and in their rural environment may not have the expertise to treat that. So we can leverage our resources from an academic urban center 2,000 miles away to treat that veteran, and to have that veteran be seen in a different system, same big system, but to be able to do that with fewer questions, to be able to do that seamlessly, and to really be able to cumulatively make the veteran experience better by offering them all the resources that the VA can bring to bear. So for us, that key piece was that 2018 legislation, again, that really opened the door to that single standard, that authority to be able to deliver care across state lines. And looking at the numbers, we looked at the numbers briefly, and actually we hadn't before. So in anticipation of this panel, I ran some numbers, and it's interesting to see because before the pandemic, and looking at after the most recent numbers as of this year, you can see a 5-fold increase in the number of encounters that were done in where the provider and the veteran are in different states. So whether that's a function of, people were traveling during the pandemic, maybe, going to other places, getting out of urban centers, we're not really sure. We haven't had a chance to really dig down into those numbers. But again, almost a 5-fold increase in the number of encounters that were done where the provider and the patient were in different states. So I will wrap my comments there and look forward to our Q&A session.
Great. And last, but certainly not least, Craig Lipset.
Thank you so much, Carmel, and thank you, of course, to the Petrie-Flom Center for setting up today's topic. As you might have heard from my introduction and from the website bio, my focus is on clinical trials, which picks up on a theme that Krista had mentioned just a moment ago. So for me, my focus is how do we enable improved access, improved resilience for clinical trials, in particular when we're running studies that are testing investigational new medicines. So what are the components for clinical trials here that are relevant for today's conversation? For one, all of our clinical trials involve somebody in the role of an investigator. Keep in mind that there is no board certification for an investigator. The qualification of an individual to be an investigator in a clinical trial has no predefined status. It is defined in terms of demonstrating that the individual is simply qualified in the eyes of the research sponsor, of the of the ethics committee involved, that individual is qualified to play that role. In most cases, investigators receive supplemental training on good clinical practices and other attributes that are needed for them to serve in that role, but it's not a role or function that's otherwise credentialed in any way, because they are handling investigational medicines. In most cases, our investigators are physicians. The other element to keep in mind when we're talking about these clinical trials for new medicines First, we have that role of the investigator, and then is this concept of investigational product, IP, which refers to the medicine that we're testing, which in many cases is exploratory. It's not yet approved. And so in many cases, we are not running a study where we're testing a medicine that could even be prescribed, but we're running a clinical trial with an investigational medicine that isn't available for prescriptions to be written. Many of our studies have a control arm, but some may use a placebo as a control. And there as well, there is no capability for a physician to write a prescription for placebo. And so the clinical trial use case challenges a lot of our norms about both physicians and the credentialing or certification around them, as well as the medicines that are I'll put in quotes, are being prescribed, but are not really, because you can't write prescriptions for many of these products. Now, you might have heard in the introduction, I co-chair an organization, a nonprofit organization called the Decentralized Trials Research Alliance, DTRA. DTRA is a nonprofit collaboration with about 100 organizations, pharma companies, contract research organizations, tech companies, health systems, regulators, and others working together on this concept of decentralizing clinical trials and making them more accessible globally. When we talk about decentralizing a clinical trial, we're talking about using technology and services that can enable visits to take place away from a traditional research site. A clinical trial is based on having a protocol with predefined encounters between a study participant and the investigator. Traditionally, those take place in research centers. Often those are in hard-to-reach locations, major academic medical centers that may make it difficult for people to participate. Certainly during the pandemic, like so many areas we're talking about today, we saw substantial upticks in adoption of these approaches because of the inability of patients to necessarily to travel to research sites, to feel safe traveling to research sites. But again, these approaches existed prior to the pandemic, like we see with so many other telehealth and telemedicine use cases. Today, we see tremendous momentum for sustaining these approaches in clinical research. We know that they're good for access. We know that they're good for helping to support inclusion, diversity, and representation in our studies. We know that they're good for resilience in an unpredictable environment to help make sure that we can enable robust follow-up of people in a research study in the case of war or a pandemic or other factors that may conspire to get in their way. And for many research sponsors today, we know that these decentralized approaches are supportive of their ESG goals and sustainability objectives, and how can we help make clinical trials green and reduce some of our impact, whether we're using video or some of these other decentralized methods that may include remote monitoring, home visits from visiting nurses, or other functions and capabilities. Now, fortunately, the commitment around this is robust. We've seen so far in both the Cures 2.0 legislative language, but also in the omnibus spending bill that was approved back in December, expectations for the FDA to produce guidance for industry on sustaining decentralized clinical trials. We saw the FDA, as well as regulators around the world, include these approaches in their guidance for running trials during the pandemic. We see this language persist in how the White House Office of Science and Technology Policy and others are approaching pandemic learnings and readiness for the future, and making sure that these decentralized approaches can remain. And so from policymakers, from regulators, and others, we see substantial commitment, and importantly, among pharmaceutical companies as adopters of these approaches, substantial commitment. If folks are interested, at the DTRA website, dtra.org, we have videos of of leaders from Pfizer, Sanofi, BMS, Boehringer, Otsuka, each sharing their commitments and strategies in these areas. And so I think, as Krista mentioned, for some, this can represent an interesting tip of the spear use case, where there may be more substantial support or willingness to embrace and accept physicians supporting remote participation in clinical trials, agnostic to border and location. We have the same hope and aspiration. We want reliable, experienced investigators to be able to support research participation from wherever those individuals may be. Well, I think I'll stop there. I'll look forward to the questions. I'm already seeing some interesting ones coming through in the thread here. Carmel?
Wonderful. So I'm going to call all of our panelists back. So I will say we've gotten some great questions in the queue. So I'm going to put a pause on my own questions, of which I have many for all of you, and ask some audience questions. The first is, what is the current status of legal protection or lack thereof for providers and patients who cross state lines to seek care that is not legal in their home state?
I can take that. There really isn't. That you are breaking the law if you practice in a state and are not abiding by the practice rules that have been set out by the medical board in that state. So if you're not licensed there and you're not abiding by the clinical standards that they've set out, then you're breaking the law.
And I think this is a good segue to something that was touched upon in several presentations. You know, as a Center for Bioethics, we've done a lot of programming around reproductive rights, especially with Dobbs versus Jackson Women's Whole Health, which has just really appended the apple cart there. I was wondering how people think that the issue of abortion, in which states are so polarized in their expectations and approaches to abortion services, will impact the development of interstate telehealth in the years to come.
I think the key is the fact that a practitioner has to be abiding by the rules where the patient is located. That's why I like to compare it to the driver's license compact. I'm originally from Michigan, and the speed limit in some parts of the state is as high as 75 miles an hour. I'm not going to drive 75 miles an hour in Northern Virginia because I'll get ticketed. So the idea that a medical board could police this better if they continue to require licensing, I think is false. I think people are either going to do it anyway, or they're going to get in their car and drive to a state where it's legal. So our position is, you know, you're breaking the law if you don't abide by the state's rules. So if you want the privilege of being able to practice across state lines, you have to know those rules. You just don't have to go through the cumbersome and expensive process of getting a license.
Lita, I want to hear your reflections, because you touched on Massachusetts laws around that I think are responding to this controversy, as well as with the Mass Medical Society. I suspect that is a group in which there would be a lot of physicians who are offering reproductive care and services that might be criminalized in other states. So how do you go about approaching this issue?
Yeah, thank you. It's obviously a really challenging topic, and we were very engaged with policymakers when our law was being developed. And I think it's important to note sort of the limitations of the law that was passed in Massachusetts. I think it's talked about very broadly as creating these, you know, sweeping protections for physicians and providers in Massachusetts, and policymakers did choose to extend the protections that were established here for care provided via telehealth that was a really challenging area for the medical society. We certainly don't condone the unlicensed practice of medicine in other states and respect, the laws and requirements. But I also, heard strongly from a lot of providers that they feel they have an ethical duty to provide access to, medically necessary evidence-based care, and view telehealth as a key way to maintain that access in states where it is restricted or prohibited. But I think when it comes to telehealth, like the legal protections that we have here in Massachusetts, regardless of whether it's for care provided in the state or if it's provided via telehealth in other states, there's only so much that these protections can do. So there are sort of professional protections that insulate a physician or provider's license, prohibiting their relevant licensing board from taking disciplinary action against them for providing legally protected healthcare services. But we haven't seen a test case of what will happen and how that will play out, when we're talking about the context of telehealth. And it's a really, really gray legal area. And one of the most important things we're trying to do right now is just educate our physician members and providers in the state and the Commonwealth about those limitations, and ensuring that, their understanding of, the risks, legal and otherwise, that they assume when providing care, whether it be in Massachusetts or otherwise.
So on to a slightly different focus. Leonie, during your presentation, I was really struck by how the VA is looking to innovate in this space to serve veterans. And I was wondering, what lessons do you think other government payer programs, agencies, maybe even private insurers should take from the VA experience?
Thanks, Carmel. I think, as I mentioned, looking at our numbers alone and that almost 5-fold increase, there's clearly the demand there. People are mobile, people are seeking other options. And as our other panelists have referred to, there are a lot of questions from practitioners wanting to do the right thing, but not sure what the right thing actually is. And having that landscape where state laws can be confusing and complex, and where different standards exist is something that we have experienced and previously had a lot of questions about. And I think the proof is in the numbers that we see as far as that real expansion of cross-state care, and really has allowed us to build things such as our national hubs. So each of our regions, each of our 18 regions has what we call a clinical resource hub. And these connect with spoke sites across the country to deliver all sorts of care, variety of specialties. The core is mental health and primary care, but all sorts of specialties. And then we have our national hubs as well. So these are things like tele-ICU, so telecritical care, telestroke, tele-oncology, providing those services at a national level. None of this would have been possible if those questions still remained about cross-state licensure and care provision. And so really now what we're looking forward to the expansion phase, is to be able to say, how can this impact the type of care that we can deliver? How can we best leverage our capacity? How can we use that to improve quality of care by leveraging that specialty expertise that might exist in some pockets and not in others?
That is really helpful, and I think an inspiring vision. And I was wondering if you had any lessons from the VA experience that you would in particular want state medicine boards, medical boards to know about telehealth licensing.
So I think that our 2018 legislation, that Anywhere to Anywhere initiative housed within the Mission Act, really gave us that authority in no uncertain terms. So Lida and Krista have referred to the patchwork of different compacts that exist. And I think that that is very confusing. A single national standard would be fantastic. And that's what we have. So I think that would be the bottom line for state medical boards is get together, come up with something that is standardized, that everybody can agree on as a national standard, and employ those principles. Whether or not legislation is needed, I'm not sure, but certainly for us, that has been a cornerstone and a key point to make things less confusing and to really allow that rapid expansion without question.
Craig, we have an audience question that I think might be right up your alley. This attendee asks, is there a concern that this type of decentralized approach for clinical trials would risk patients presenting to their local facilities with complications or adverse events that are difficult for local providers to evaluate or understand?
Great question. First, I should note that many decentralized trials are actually various forms of hybrid where there may still be a site not too far, but we know that even for our traditional studies that use brick and mortar conventional sites, that patients do not necessarily go to the research site in the event of an emergency or an urgent matter. They may go to their more local treating physician. They may go to a local emergency department. The likelihood that they would travel a great distance to go to the research site or to the institution that is where the research is taking place is less likely the more severe the emergent issue may be. In other cases, we have patients who travel, whether snowbirds or otherwise, who simply wouldn't be realistic for them to go back to the research site in the event of an issue. So for all of these reasons, we rely very heavily on call centers. We rely very heavily even today with brick and mortar studies to have investigators answering questions over the phone if there are local care teams that are getting involved and trying to understand if the safety event or medical issue that a patient is facing is actually related to the investigational medicine in the clinical trial. One last note on this topic, there are only two primary guardrails when it comes to clinical trials from a regulatory and ethical perspective: patient safety and data integrity. And so related to this question, of course, first and foremost, is making sure that processes are always in place to protect patients from a safety perspective. And from a data perspective, we still need systems in place when a patient goes to an emergency department or a local care provider to understand from a safety data perspective what happened in those encounters, whether it was brick and mortar or decentralized.
So next, and this is open for the entire panel, I want to harken back to our previous event in this series in which we had a clinician raise the issue of follow-up phone calls and whether they're allowed. So she was describing maybe a patient physically comes to see her and they've developed a care relationship. The care is happening within the state she's licensed, but then they go home. And the normal course of action is to have a follow-up call or such. Usually no prescribing or diagnosing, just making sure everything is going well. And she reported, and some other clinicians agreed, that prior to the pandemic, this was sort of considered an acceptable course of action, even if you had to call across state lines. But now, with the shift to sort of tamp down on unlicensed telehealth practices across state lines, they're hearing from counsel, no, if you're not licensed in the home state, then you can't do that follow-up phone call. Either the patient has to come back to your state or there needs to be a handoff. Can you guys talk about whether that is part of the practice of medicine, whether the clinician doesn't need to be licensed to have those follow-up calls?
I just personally went through this. I had hip surgery at MedStar in DC, but I live in Virginia, and every other appointment was telehealth, but my surgeon was licensed in all 3 jurisdictions in the DC metro area, so it wasn't a problem. But for other regional medical centers and areas, that might not be true. And so, I would have had to, as a hip patient, find a ride to my appointment. So it seems like follow-up should be its own category. It's going against what I just said, which is that we shouldn't be doing this, incrementally, because why is one disease state, why should you be allowed to do it for one disease state and not another? But if it's the low-hanging fruit, then and it can get done, then it should.
Yeah. Do others have thoughts about follow-up care? Is it practice of medicine? Is it kind of so minor that, hey, what does it matter, et cetera?
I think there's a lot of questions about whether that would be considered even the same episode of care if you're just following up with the patient. And so I think I would agree. I mean, that's what we hear from our physicians all the time. It doesn't make any sense if we have an established patient, they have a physician-patient relationship, and they go out of state. They want to be able to continue to provide that care to them. And I think in these circumstances, it absolutely makes sense.
So with that, I'm mindful that it is 1 p.m. East Coast time. We're so grateful to our panelists for taking time out of their busy schedules to explain the issues around interstate telehealth practices and physician licensing for us. Thank you so much. This has been a wonderful conversation.
Thank you.
Thanks for having us.
Thanks for the opportunity.